Hello, everyone. Nice to see everyone again. So we are going to wait a couple of minutes for everyone to join, and then we will start with a short introduction, and then we will just start with Giovanna's Puoti presentation of today. So I can see that even more people are joining. So hello, everyone. We are still waiting a couple of minutes, and then we will start with our today's webinar, the first webinar of this year.
I'm looking forward to this webinar, Mara. We're going to start the year with one of our young ESPGHAN representatives as part of our webinar series, and we hope that you enjoy the topic as much as, well, any pediatric gastroenterologist does, I guess.
Our colleague and friend, Giovanna Puoti, is going to be the speaker today. So we are welcoming her. And we are also very grateful that she responded to our invitation.
Hi, everyone.
So we are going to wait a couple of minutes just so everyone can join the webinar, and then we can start, if that's all right with everyone. Okay, so hello everyone. I hope most of the people joined already this webinar. So thank you everyone for taking the time to join our webinar. We hope that you are going to learn something from this. This is our first webinar of this year. this webinar is part of our Young ESPGHAN Webinar Series, and today we are going to talk about managing intractable constipation, which I know that many of you may have encountered during your clinical practice. And today we are going to have our colleague, Dr. Giovanna Puoti, going to talk about this topic. But before we start with our webinar, I'm going to give you a short introduction about what Young ESPGHAN is doing and what is our mission. So first of all, we like to promote high quality research and training. We like to organize activities for the Young ESPGHAN members and to represent the interest of this community within the council and the society. So regarding our educational events, I would like to mention the mentorship program, which is a forum for ESPGHAN trainee members to meet and receive support from more senior members. And we already had 2 previous editions, and don't forget that the deadline for this year's edition will be on Valentine's Day on the 14th of February. So please, if you would like, just join, because it's a great opportunity to receive more information from more senior members. So during each year, during the annual Congress, we have a Young ESPGHAN Day. Last year, of course, it was during the conference in Milan, where we had many activities. We had the activity of get an award and showcase your work, develop your skills and build your career. And of course, we had the Young ESPGHAN session that ended with art and chocolate. Of course, also during the conference, we have like a period of time where we can meet the president of the society and where we can ask him all sorts of questions in order to develop our young society. And also, I would like to present you the members of our Young ESPGHAN committee, because I think it's also important for you to know who is behind all our projects. So I will start with Anne-Marie, who is our Young ESPGHAN chair and who is also here and joined this webinar. She's also a moderator of this webinar. Vangelis, who is the secretary of the society. Petra, who is the treasurer. Anna, who is a PAC rep. Pinar, who is also a new member of our committee. Francesca, who is the social media ambassador and who is doing a great job. Also, you can check all her posts on Instagram. Myself, Mara Ionescu, because I think I forgot to mention who I am. Also one new member of this young committee. Jose, Giovanna, who is also going to be a speaker for today, Harwin, and Beno. So this is us. Also, this is a picture that was taken last year during the conference. So if you're not a member yet, please join us. You have so many benefits as a training member. So you can have a subscription to the GPGN journal. You can also have reduced registration fees for everything from courses to the ESPGHAN annual meeting. You also have the opportunity to apply for research grants and awards. So you have many things that you can learn and you can do as a training member. In order to become a member, you have to, of course, fill an application form on the website. You need a CV and also a letter of support from a full member not serving in the council. So if you want and you would like more information, you can download the ESPGHAN app, and you can also follow us on social media. You can follow us, for example, on Instagram. ESPGHAN has, as I mentioned, many opportunities for you. There are new free courses, for example, the management of foreign body ingestion in children. And also you can go to other cities and join other courses such as the GI Immunology Masterclass and the Nutritional Assessment, which will be in March in Naples and in April in London. However, the deadline for these two courses has already passed, but you can submit your application for the following courses. And of course, we would like to see you in Helsinki this year, where we will have two sessions. We will have the Young ESPGHAN Afternoon Workshop, which will be on the 14th of May, and where you can gain invaluable insights into statistics and meta-analysis under the guidance of renowned Professor Maurice Gordon. So basically, you will gain a basic understanding of statistics. You will learn the fundamentals of systematic reviews and meta-analysis, and you can identify the importance of peer review in your daily practice and career progression. So basically, you will get the chance to decode systematic reviews, meta-analysis, and peer review essential. So please join our Young ESPGHAN afternoon workshop. And also on Saturday, we will have on Young ESPGHAN Saturday session where you can navigate your clinical cases. And if you ever had any sleepless nights thinking about a patient's case, if you have encountered clinical scenarios that haven't really gone the way you thought, we have basically created this perfect opportunity for you to ask the experts in the pediatric gastroenterology, hepatology, and nutrition. So we will start looking for clinical cases to be discussed with a panel of experts. So we are going to start the submissions very soon. So if you have this clinical case that gave you sleepless nights, please just submit it, and we are going to discuss this case with a panel of experts during the annual meeting. Regarding our webinars, so we started this year with constipation, but also we are going to have another webinar in March, April, and June with different topics. We will have refractory gastroesophageal reflux disease. We will have the role of machine learning and AI in pediatric GI, and also in June, the gut-brain connection and the microbiome's role in DGBIs. So these are the next three topics, and we are going to let you know what are going to be the following ones, because exciting new topics will come. So without further ado, I would like to introduce Dr. Maria Giovanna Puoti, who is a consultant in pediatric gastroenterology at the Santo Buono Pausilipon Children's Hospital in Naples, in Italy. She has trained in pediatric gastroenterology at Great Ormond Street Hospital in United Kingdom, where she completed fellowships in pediatric neurogastroenterology and motility, in mucosal immunology, and intestinal failure. So basically, her special interest is, of course, pediatric gastroenterology, neurogastroenterology, and motility. And she is currently the young representative in the gastroenterology committee of ESPGHAN. As I mentioned, she is our colleague, but also, moreover, she is in the faculty of research curriculum of ESPGHAN since 2023. She is a member of motility special interest group of ESPGHAN, and also in the neurogastroenterology group of Italian Society of Pediatric Gastroenterology. So I would really like to thank Giovanna for accepting our invitation, and she's going to talk today about managing intractable constipation. Thank you. And also, I would like to tell all the participants today that during the presentation, you can ask any questions you want in the chat box, because at the end of the presentation, we are going to ask Giovanna everything that you would like to know more about this topic. So thank you, everyone, and enjoy this presentation.
Thank you, Mara, for the great presentation. Thank you, ESPGHAN, for inviting me to present this talk today. So let's start sharing my presentation. Okay. So I'm going so to discuss basically more into the management of intractable constipation. And this is the outline of my presentation. I will go through the definition and then going through the epidemiology, the pathophysiology, the etiology, and then I will focus more on diagnostic and treatment strategies. Intractable constipation is the inability of children to pass stool even when the maximum laxative treatment, daily rectal stimulation, behavioral therapy, or toilet training program for more than 3 months have failed. Sorry, but this, I'm very sorry because I can't move on. Okay. So if we look at this definition, obviously is not explained very well what maximum laxative treatment means, and that opens some doubts that we will see that in more detail later. Looking at the prevalence of pediatric constipation, we will see this is a very common problem, and actually the prevalence range among 5 to 20% in the different countries where this has been studied. And among these constipation, we will have a prevalence among 10 to 30% of intractable constipation. So in general, constipation accounts for 3% of all general pediatric outpatient visits, and up to 25% of these cases will be seen in pediatric gastroenterology tertiary centers. So this is something all of us will deal with. And the prevalence of childhood constipation varies from, as I already said, from 5 to 20%, and it affects 1 to 3% of all school-age children. In more than 90%, the underlying mechanisms remain unknown, and the patients are labeled as having idiopathic or functional constipation, as we know. And the Rome 4 criteria define this condition. We know in the next year are coming the new criteria. Another important thing is to know that 25% of all children still have symptoms into adult, and 50% of children are still symptomatic after 5 years, and 25% will still struggle with constipation after 10 years. So it's important to look into the pathophysiology of the constipation. There is a vicious cycle of constipation, usually starting with a first event, a social event, or there are triggers such as the change in formula from breast milk to formula, or the weaning, or the toilet training time, when the child has an uncomfortable, painful defecation, and that is the moment when the child starts associating defecation with the pain, is frightened of defecate, so it holds the stool, and by holding the stool will become more and more hard because it will increase the absorption of water, and then this will create more difficult to pass stool, and when the child pass stool will have again pain, and this vicious cycle, if it's not break, as it will continue, it will determine the dilation of the rectum, a more distended rectum, causing overflow incontinence, rectal hyposensitivity, and the gradual loss in urge to defecate. So this is essentially what is going to happen, and obviously with a big fecal mass in the rectum, the overflow incontinence will start, and this is what a chronic constipation can cause, essentially a megarectum. So the first question I would ask is does a functional disorder become organic? Actually, in the literature, we have some evidence. In this study, they have compared a group of patients with no constipation with the group B who has a slow transit constipation. And the histology showed that this group present features of enteric neuropathy with the reduction in the total number of enteric neurons, hypoganglionosis, reduction in interstitial cells of Cajal, and reduction in neurotransmitters. So if we think of constipation now, looking a little bit more into the etiology, the constipation is one symptom, but actually it can underlie numerous etiologies. And the etiology, as I say, the majority of time, more than 90% is functional or idiopathic. But we need to think even that constipation can be caused by other conditions such as intestinal, nerve, or muscle disorders, Hirschsprung disease, or intestinal neuronal dysplasia, visceral myopathies, or neuropathies. It can underlie an anatomic malformation, anorectal or of the abdominal muscles, metabolic conditions such as hypothyroidism, hypercalcemia, cystic fibrosis, diabetes mellitus, or neuropathic conditions such as spinal cord disorders or connective diseases, or even the use of some drugs, this slow the colonic transit can cause constipation. And even some other conditions, which some of them can be more common, such as celiac disease as cause of constipation, or food allergies, and some that are very rare. I find them very rare, such as heavy metal ingestion, vitamin D intoxication, or botulism. What is important is when we have a child, it gets hard to treat for this constipation, to look at the alarm signs and symptoms of constipation. First of all, starting with the history, the clinical history can be suggestive of some underlying organic conditions, such as a constipation started before in early life, before the first month of life, passage of meconium delayed longer than 48 hours. But for this, be careful that children, they were born with a low birth weight or preterm, they can have a delayed passage of meconium, even if they do not have any underlying condition such as Hirschsprung disease. Or if there is a family history of Hirschsprung disease, if you have, if you ask about the consistency and the form of the stool, because if they have a ribbon stool, can be suggestive on in Hirschsprung disease. If there is blood, or if there is a history of fever, failure to thrive, and look at all other things we can see from the physical examination. For example, the presence of an anal fissures, sacral dimple, or if there is a gluteal cleft deviation, if there is an abdominal distension or perianal fistula, the displacement of anus, if there is a malposition or there is a abnormality of the anus. But what else is very important to look when we start assessing a child with constipation, particularly if this has already been treated and it does not respond to first-line treatment? If there is a fecal impulsion. This is very important. The thing is we need to get the bowel empty and keep it empty, okay? So because if we do not assess for fecal impaction and do not perform this before starting our maintenance treatment, the risk is that our treatment will fail, very likely. And how is defined the fecal impaction? This is defined as either having hard mass in the lower abdomen on physical examination, or as a dilated rectum filled with a large amount of stool on rectal examination, or an excessive stool in the colon on radiography. But is really an abdomen X-ray useful for this? Actually, if we look into the literature, there are different scoring systems to assess the fecal loading, but it has been reported an intra-observer variability of this. So reporting and interpreting an abdominal radiographs remain quite an art, we can say. And the study has compared the rectal the digital rectal examination versus the abdominal X-ray used as gold standard. They have found that the rectal examination to assess the fecal loading has a positive pediatric value of 85%, with the negative predictive value actually only on 50%. That means if we find it on rectal examination, is very significant. But we need to consider that the digital rectal examination is quicker, cheaper, and does not cause radiation. However, it might be impossible to perform in some children, and so the abdominal X-ray, if you have doubt, it can help. Consider that the recent latest guidelines from 2014 from ESPGHAN and NASPGHAN suggest that the the digital rectal examination should not be used to make diagnosis of constipation, but in the presence of alarm signs and symptoms can be used to assess the anorectum area and even to assess the fecal impaction. And the routine abdominal radiograph should not be used, it's not indicated, but again, if we think there is a fecal impaction, we cannot perform the physical examination, then we can use it. So now let's go to the management. So first thing, if the child is impacted, obviously we should treat the impaction. And this table summarizes a little bit which are the available treatment. Personally, I think you should discuss with there is no superiority of enema against the oral treatment. In infants, you can prefer the rectal treatment. In older children, you should discuss with family. The most common used based on the latest guidelines is actually the polyethylene glycol 4000 with the doses of fecal impaction from 1 to 1.5 grams per kg per day with the maximum of 6 consecutive days. This treatment can be performed even at home. If this study comparing, as I said before, the enema with high dose of oral polyethylene glycol actually did not show any superiority of one treatment on other for the disimpaction. There are one recent evidence that actually in the fecal impaction with the polyethylene glycol plus sodium picosulfate, so the addiction of stimulants can be, for the fecal impaction, can be superior to the only use of polyethylene glycols. And this can have a good effect not only on the primary outcome assessing the disimpaction, but even on the secondary outcome, which were the effect on stool frequency in the days after the disimpaction. And the other good outcome was that the side effects were significantly less with the use of the combined treatment compared to polyethylene glycol. And these were the doses the authors have used in this trial. The doses are based on the child weight, body weight. So once we have disimpacted the child, we should start a maintenance treatment. And as we can see, this is the table summarized the treatments suggest in the latest guidelines, but the first line treatment should be the polyethylene glycol with doses ranging from 0.2 to 0.8 grams per kg per day. The problem with this treatment is actually the evidence. For polyethylene glycol, we have a high quality evidence compared to placebo. We have even high quality evidence that compared the polyethylene glycol with the lactus, showing some of them actually that polyethylene glycol is more effective than lactulose, but we do not have other good high quality evidence with the stimulants such as senna, basacodyl, and the sodium picosulfate. But what's the problem with the maintenance treatment when the problem is if you have this condition, this situation, and you will treat this child with the polyethylene glycol, very likely after disimpaction, because this child with this megarectum probably is impacted. After he started the maintenance treatment, by the time he will the medication will cause the will make the stool softer, but by the time the stool will arrive into the rectum and they will feel this very enlarged rectum and the child will feel the sensation to defecate, it will be again impacted because there is the megarectum. So this is the problem, and then this is the reason because probably more medication needs to be added in these cases, and these cases are not actually intractable, but we need to optimize the treatment. And in these terms, I want to highlight how in the literature we do not have high quality evidence for the use of this medication, but in terms of safety, we have some evidence which actually we can rely on, and they show that this treatment are effective even in the long term. Other treatment also we can use is the novel agents, the new treatment. We have the prosecretory agents. These modulate the epithelial channels in the intestine, stimulating the secretion of fluids into the lumen and increasing stool volume, aiming to accelerate the colonic transit. And we have the lubiprostone and the linaclotide. The lubiprostone activates the type 2 chloride channels on enterocytes, and the linaclotide activates the guanylate cyclase C receptor. So the lubiprostone actually, unfortunately, it showed efficacy in a previous open label study, but in this randomized controlled double-blind trial, it showed in this slide, it didn't show superiority compared to placebo. And instead, the linaclotide in a very recent double-blind placebo-controlled randomized multicenter study, a phase 3 trial, showed an efficacy, and so it can be an option for if other agents do not work. And we have then the serotonergic agent. We are talking mainly about the prucalopride, which is a selective high affinity 5-HT4 receptor agonist, whose mechanism is to increase fluid secretion and gut motility. And this initial open label study showed that a dose of 0.03 microgram per kg per day was effective in a trial of 8 weeks period of treatment, and with a good efficacy and tolerability profile. But unfortunately, the year after, a new trial came up, and the prucalopride was no more effective than placebo for children with functional constipation, either at 4 and or 8 weeks. So if we have tried all medication and no one of these medication has been successful, what do we do? What do we do if the treatment fails? So we should always think about the reason. If there is any reason, we can optimize and why because the treatment failed before thinking this is really an intractable constipation. So we should think if there was a poor compliance, if the treatment can be further optimized, if there is something we have missed, that we have not searched for an organic condition. So the first thing I would recommend to do is to re-educate, reassess, and monitor the treatment adherence. Personally, regarding this, I would suggest when you review this patient, what do I do is not asking, are you taking your medication? But I ask the question like, how many times did you miss your medication? Because then you make them feel more comfortable to talk, and maybe they will start saying, oh, really, I missed that every 2-3 days, and that means the treatment actually is not done correctly. And there are actually in the literature the evidence that show that the adherence is and there are factors associated with adherence, and probably even the parental illness perception, the satisfaction with the treatment. Probably they start the treatment, is effective, and then they start to not be compliant to the treatment anymore. Also, regarding the treatment adherence, if we look at the study from New England Journal of Medicine, we see that by increasing the dose of the daily dose of treatment, the compliance to treatment declines. So my suggestion is always to try to give one dose of the medication if you can, rather than splitting the doses. Another reason, obviously, is the disimpaction. So think again about this. Do you need to disimpact the child? Maybe he was not disimpacted correctly. Maybe the disimpaction, if done at home, didn't work, and you need to bring the child in the hospital and do it under your supervision. And then think about changing or optimizing the treatment. The most common treatment used is polyethylene glycol. So mainly you will see a child he failed the polyethylene glycol, and you need to think to add other medications such as Senna or sodium picosulfate or bisacodyl. Here are reported the doses you can use, or the new agents. And also regarding the medication, try to optimize the doses as much as you can. Try if you can even combine doses. I know this is something where there is not a lot of evidence, but experts in motility and people, they deal with really hard to treat constipation. They will do that. They will try to combine more stimulants as well, because the different stimulants works on different pathway and mechanism of action. So you can try to combine these as well. And if all of that has been done and checked, you have reassessed adherence, you have re-educated, you have done different doses, increased dose, the different medication, combining the medication, you have this impacted the child, but nothing works, then you really need to treat this constipation. Maybe it's intractable. So you need to go through investigation. And the first step would be to do basic tests, blood tests for celiac screening, thyroid profile, the serum calcemia. Think about the even food allergies. If the child has family history and personal history of atopy, maybe a trial with cow's milk allergy can work. I would say this works better for small children rather than older, but still there are some data reporting that food allergy could cause the constipation. But we even need to be aware that this study showed that among a large cohort of constipated children, more than 7,000 screened for this causes, the diagnostic yield was actually very low, and the celiac disease was found in 3.2%, hypothyroidism in 7.5%, and no child was found to have hypercalcemia or other causes like lead poisoning. So the cost to screen of these children was actually very high. Was a mean cost for patients of 1,000. The total screening cost was 4.7 million, putting so a burden and a very high cost on the healthcare system. Then another test you can use, and I think is easy to perform if you know few tips on how to do it, is the colonic transit study using the radiopac markers. Basically, with this test, it will give you an indirect measure of how long take your colon to move, and you will give markers at the first day, second day and third day, and the fourth day you will perform an X-ray. It's important to give the markers and perform the X-ray at the same time every day and perform the test after disimpaction. So the before starting the test, you will disimpact your child, and when you start the test, you will not give any laxative, any medication, or act on the motility. So you will need to have a complete normal situation to study the colonic transit time. And what the information can give you is to subtyping the constipation in a pelvic floor dysfunction or slow transit constipation, because on the X-ray you will see how many markers are still present. Usually there are different protocols for this test. This is the most common use in pediatrics because reduce the number of X-ray you perform. So on day 4, when you perform the X-ray, you will count the markers and you will see where there are. If they are mainly in the pelvic area and they are more than 20% present, there is a pelvic floor dysfunction. If you have more than 20% along the colon, you will have a slow transit constipation. So also important thing, and I think this is a tip I can give you, this test is very useful to differentiate between retentive and non-retentive fecal incontinence. Particularly if you have a child with soiling, you have doubts around the diagnosis, do this test and check if actually it's constipated or not. The other test, and this gets a little bit more of competence of specialists in motility, is the anorectal manometry. This is a diagnostic tool that provides a qualitative and quantitative assessment of anorectal motor functions, measuring intraluminal pressures of anorectal activity. The image here is is not in high resolution, but is in low resolution, where the pressure were recorded as a line, but actually now we'll read it in a high resolution. And what we do is after the child has performed an enema, so the rectum is empty, we will insert a catheter who has a pressure sensor along his length and there's a balloon on top. And we will perform a protocol by recording initially the resting pressure, and then if the child needs to be collaborative, we will ask him to do different things: squeeze, bear down. If we fill the balloon, we will inflate the balloon gradually. And also when we inflate the balloon gradually, we will check for the recto-anal inhibitory reflex, which is an involuntary reflex when you essentially fill the rectum with the balloon. We will have a involuntary relaxation of the internal anal sphincter. It's essentially mimicking what's happening when the rectum is full of stool. And in pediatrics, the absence of the rare is more suggestive usually of Hirschsprung disease. But personally, in chronic constipation in children, older children with long history of constipation, absence of rare may be related even to megarectum, because the rectum is so dilated that actually even inflating the balloon, this cannot elicitate the reflex. And this is the image when the rare, despite of the inflating of balloon, is actually absent. We will not have any relaxation. So here summarize what I said before, the thing we can assess with anorectal manometry. And if the rare is absent, obviously the child should be referred to surgeons and be assessed with the sanctioned rectal biopsy, and probably in older children is more indicated than intraoperative biopsies to assess for histology to see if Hirschsprung disease is confirmed or not. Another test useful, it can be useful, is the spine magnetic resonance imaging. Personally, what I do is always before performing this is to send the child for a neurosurgery consultation. They help me a lot because they assess clinically the child with the neurological examination, and they perform some neurophysiological tests before, and they gave me the indication to perform the spine magnetic resonance imaging. In this study, actually among a group of intractable constipation, 9% of them was found to have a cord abnormalities, and of them, 75% had tethered cord. Now we're going towards a test is actually much more complex, and this is a test is performed only in few centers around the world. I think in Europe only in 2 to 3, 4 centers, and this is a colonic manometry, which actually the concept is the same of anorectal manometry in terms of how the test works. There is a catheter essentially with the pressure sensor along its length, which in this case needs to be placed along all colon, usually in the hepatic flexures on the right colon, and it needs to be placed by an endoscopy, so it's even an invasive procedure. And after the placement, it will be clipped, it will placed by clip during the endoscopy, and after the child will have an X-ray to see if the catheter is displaced or is well placed. And the main indication for performing the colonic manometry is to assess children with severe constipation are responsive to pharmacological treatment associated with a slow transit constipation with no evidence of evacuation disorders. To give you an idea, this is what we see on a colonic manometry. Basically, we do the first part of the test during fasting, and then we will feed the child. We will record the postprandial period, usually by 1 hour, and then we will give bisacodyl at 2 different doses. And we will see if the feed or the bisacodyl stimulates the high amplitude propagated contraction. This is actually what we see in low resolution, and this is what we see in high resolution. What we look for, as I said, is the high amplitude propagated contraction. This is the normal colonic pattern, essentially, where there are this contraction propagating along the colon, and they should happen at a specific frequency with the specific amplitude. So we know the characteristic and we study this. And this is the image in high amplitude. The bicycodil-induced high amplitude propagated contractions has been actually characterized, and they were found in 93% of children with treatment to refractory constipation, and which showed actually the majority of them only a synchronous pressurization in the rectosigmoid. And this is the colonic manometry pattern we can actually found. They can be from normal or hypomotile or a completely absent high amplitude propagated contraction or completely abnormal. We need to clarify that this test needs to it shouldn't be used to diagnose or to change treatment. This kind of test should only be used when we are thinking and considering surgical management, because it guides the surgical management, because it can give us information if there is a segmental dysmotility, a total dysmotility, so it can guide the surgical strategy. And what do we do if all treatment, pharmacological treatment have failed? We have gone through the test I have said that we didn't find an organic causes. I think the first step should be the transanal irrigation. This is, I don't know who is familiar with this, maybe later we can talk about, but this is a way to perform an irrigation through inserting the cannula of this device through the anus, and it works at a specific pressure. And these are the indications. As you can see, among the indications, there is the medical therapy resistant functional constipation. This treatment actually has just very few complication side effects. The bowel perforation is almost never seen with this treatment. The main thing are the child can complain pain, emotional distress. I would say the problem is the compliance of the child with treatment, because some of them, they do not accept this, the transanal treatment, but the success is very high, because actually the average success rate is 78% for fecal incontinence and constipation, and the overall improvement is 84%. And this actually a treatment can really change the quality of life of a child, particularly because the child that needs this treatment is a child with chronic constipation, long history, and we will soil as well. So on the soiling will treat will work very well. If the Perisin, the transanal irrigation, is not an option, you can use the antegrade continence enema, which is actually a way to perform the irrigation by a stoma, performed surgically by an appendicostomy or cecostomy. And for both treatment, transanal or antegrade continence enema, you can use the PEG solutions, normal saline, and you can even use some stimulants and other medication. And actually, as you can see in the table from this study, the treatment was more successful by adding stimulants. And usually when they do this, the irrigation, the time to start the evacuation is quite quick, with the average time of a few minutes, up to 60 minutes. And the time to complete the evacuation is usually 60 minutes. If we have a pelvic floor actually problem, or a dyssynergia problem, the intraanal sphincteric botulinum injection can be an option. The thing is that this treatment needs to be administered under general anesthesia, because you will basically inject the average amount is 100 units diluted in 1 ml of saline. We will inject it at the level of dentate line in the 4 quadrants of the anal sphincter. And the real problem is the efficacy of this treatment is temporary. It will work for from 3 to 6 months. We have now a paper from the ESPGHAN, from the endoscopy procedure group of ESPGHAN, saying that the botulinum injection could serve as a temporary intervention for children, as symptoms frequently improve with time in conjunction with patient maturation. And this treatment should be used as in treatment children do not respond to pharmacological treatment, and as maybe as a bridge to an improvement. Another treatment is the neurostimulators. These are not widely available. They are expensive, but where they are available, maybe a trial with this can be given. They can be placed around the abdomen. Usually this is done at the beginning to test if the treatment works, and then they can be implanted. They can be implanted at the level of sacral or posterior percutaneous tibial nerve. And in these studies, they have compared the antegrade continence enema with the sacral nerve stimulation. And as we can see, they were actually both working, but the sacral nerve stimulation appeared to be more effective for fecal incontinence, and the antegrade colonic continence enema was more effective in improving bowel movement frequency, the abdominal pain, and to allow for the discontinuation of laxatives. If all these treatments have failed, we need to consider surgery. And this is the time where probably exactly the referral to the Tertiary levels Center of Neurogastroenterology and Motility is indicated to consider a colonic manometry that can guide the surgery strategy. The approach can be used are different. They based on what you see on the diagnostic test. You can think even to just divert the colon and then reassess the colon after a period of time, which usually is years, and then reassess the disconnected colon with the colonic manometry, see how it works, and then consider if it can be done a reconnection, or if a surgical strategies of colectomy, which can be a total colectomy or hemicolectomy, different kind, can be considered as successful surgical strategy. Looking just at the end, I just want to see something on the prognostic factors that if you see at the graph on the left, the children were treated after more than 3 months of symptoms of constipation. They were actually significantly less chance of having a success of their treatment. And also from the literature, we know that non-compliance with treatment is responsible for the persistence of constipation and the soiling. The primary care physician actually tend to undertreat the child with constipation, and that can cause this delay in treating, and children with the more than 3 months of symptoms, and then with the more difficult to treat constipation, and delay in treatment so is negatively related to recovery. So the messages I would like you bring home from this presentation, where a lot of things have been said, but first of all, we need to be careful before label a constipation as intractable, because we need to re-educate, reassess, retreat, optimize the treatment, consider that few pharmacological treatments options are available, and even if we do not have a lot of evidence, we should use it and combine them. And remember that the fecal disimpaction, if the child is impacted, is essential to have a good outcome of your maintenance treatment. Consider if the treatment is not working, rethink. Maybe there are alarm signs and you need to exclude organic causes. If you can use transanal irrigation after all pharmacological treatments have failed. And if you have doubts that on your diagnosis, particularly in a child who has soiling, use colonic transit time, which can be very useful to differentiate between retentive and non-retentive fecal incontinence, and refer to specialist center in neurogastroenterology and motility for children if this constipation is intractable, you are struggling with treating it. Thank you for listening, and I'm happy to take your question.
Thank you so much, Giovanna. It was a really, really nice talk. I hope that things are clearer now for everyone. So I would like to start with a question. So you mentioned about allergies and exclusion diet. So before you can actually call it intractable constipation, do you often start an exclusion diet even if the patient has no allergy history or something?
No, personally, if what do I do is from the from the consultation, I try to understand if there is a history of personal atopy or family atopy, if there is something correlated to food ingestion, because if there is nothing about this, in older children, obviously, I don't use the trial of food elimination. Because this could, you know, it's very rare. It can be, but it's rare. And if you don't have anything else that will support you this history of allergy, actually the chance this child has a constipation related to allergy is almost 0%. So you need to look if there are other history of allergy. In this case, yes, you can think about this.
Perfect. So I would just like to ask you one of the questions one of our participants asked. So if we don't have PEG, how many times can we use magnesium?
They do not have PEG. Okay, so can you use maybe rather than magnesium lactulose? I would prefer this rather than using magnesium. But this is my personal experience. But in case you have this medication, you can use it. I know, you know, as I said, the evidence are very, very limited, but I think you should try to optimize what you have to treat your constipation.
Perfect. So what is your experience of using stimulant therapy as maintenance therapy?
Yes, I actually use the stimulant laxatives, and obviously what is my experience is then children are referred that they have already failed some treatments, or they have already failed the PEG. I reassess the child, I disimpact, and because I am tertiary level, I'm already at the step where I do the colonic transit time. And so if I find a slow transit constipation, obviously it's almost clear I need to use a stimulant. So I use it even in the long term. As I reported, there are some few evidence reporting that they are quite safe, even if you use it in the long term. And there is a latest evidence on use of bisacodyl that even using by long term, 70% of children were be able to be weaned off from bisacodyl. So the most important thing in the chronic constipation is to get it emptied and keep them empty, because by emptying regularly and allow a clear, soft passage of stool every day, you have the chance to reduce this colonic dilatation, rectum dilatation. If you don't do that, then basically this vicious cycle will never be back.
Okay, so there is one participant asking for how long stimulants can be given, but I guess
yes, yes, exactly. We do not have any evidence saying in the long term we can use it, but we are in the intractable constipation. We are talking about a field where is more experience based rather than on the evidence. So I don't have the exact answer, but what I can say, I have experienced myself in my clinical practice. Children, they have used this medication for years, and actually this safe.
And another participant asked, would you recommend cutting down milk amount for toddlers with constipation?
No, there is from the ESPGHAN guidelines, there is actually no evidence that improving, reducing the milk or improving, for example, increasing the fibers or the fluid intakes will improve the constipation. But what you need to do in your consultation is to assess if the content of fibers and the liquid in the diet is adequate to the body weight of the child, to the body weight and age. Because if it's not adequate, you should improve this. But again, in the intractable constipation, I don't think this will work. Maybe it can just improve the amount, reduce a little bit the amount of PEG, polyethylene glycol you use, but you still will need to use the medication.
Perfect. And Another participant asked, how should constipation be managed in children with autism?
Yes.
Difficult.
Yeah, no, this is tough because I think the group of children with autism is a group of child where the constipation is mainly obviously caused by the withholding behaviors are very predominant, essentially. And so I think you should absolutely use the polyethylene glycol. And before you start the maintenance treatment, you should assess the child for fecal impaction. This can be quite difficult on physical examination, obviously, in these children. And this, if this is not possible, as I said, maybe try to use the abdominal X-ray, or otherwise consider if there is fecal swelling. The presence of fecal swelling is almost always due to the presence of fecal impaction. So disimpact him and give the polyethylene glycol. I appreciate maybe the question is because these children will refuse taking the medication, but I do not have the right answer for this. What I do with the parents, I'll try to tell them to try to give it in everything they can and the child prefers. So for even if it's not a liquid, but something the child eats, but try to give it to them. I know this is not the best thing because it should be melted in water, but.
And do you think that probiotics can help children with autism and constipation?
What? Sorry?
Probiotics would help children with autism and constipation, because there were many studies relating.
Yeah, there are no evidence about the use of probiotics in treating the constipation. Different if we have irritable bowel syndrome with constipation, it's a different thing. We do not need to confuse this. In this case, there are some evidence about two specific kind of probiotics that can improve the pain, but still you need to treat the constipation. Yeah.
So do you suggest to change or alternate stimulants over time?
Okay, if it makes sense to change regular.
Like Senna with Basacola.
No. I think you need to find the treatment it works and reassess frequently the child, particularly at the beginning, explaining all the mechanism I've explained to you. What I try to do is in my consultation, I always explain to the child and to the parents, particularly to the parents, what's happening. There is a big dilated rectum, and if we don't keep them empty, the cycle will always continue. And if I find the medication they work, I will continue this medication. I will not change them. There is the possibility maybe they do not work. So, and what I do is after a period of time where the child has been, and it should be months for me, because when you are in that, even years actually, when you are in the situation, you have a big dilated rectum, this is not something you can revert in 1 month. The guidelines suggest to do the treatment at least 1 month without symptoms. This is for not complicated, let's call that like that, not complicated constipation. In case of intractable constipation not related to other organic causes, you will need to continue this treatment for long term, in the chance that the colon and the rectum, the dilated and the rectum and colon will return, will revert.
And there is like a test that you can do to see if everything is all right.
Mara,
is there any test like you can do to see that everything is all right again, like the bowels work properly? Do you repeat the pellet study or?
You mean if by the time?
Yes.
Okay. What you could do, consider if you have performed the nanorectal manometry, actually the sensation and the rare was at a very high level of volume, maybe you could consider performing that. But this is, I want to clarify, this is not written anywhere. What you can use for the megarectum is actually the contrast, the study by the enemas and basically the recto-pelvis ratio could be used as a sign of megarectum, but it's very subjective. I would not use it. It's the clinical symptom should guide you, because if a child, despite it's not impacted, is still soiling, there the problem is the megarectum.
So Salman asked, should we test for IBD in patients with intractable constipation?
Yeah. Here the risk, is I don't think a child who has only intractable constipation has a history of years of constipation has IBD, because obviously if you have constipation itself can be a symptom of inflammation, but at some point, if you have a child who has intractable constipation with this long history, some other symptoms should have come up to justify, you know, looking for an IBD. And another thing is the test can be a little bit misleading, because if you check the calprotectin in a child who is constipated, actually can be, I would say, not very, very high, but it can be even high, like with the cutoff of 300, 350, because the calprotectin is released by the neutrophils, and some neutrophils will be anyway in the even if you don't have an active inflammation in the colon wall, and then if the transit is low, well, there will be more calprotectin, so it can be misleading. So I think it's the clinical history should guide you, because if you have a child with long history of constipation, I don't think constipation itself without any other alarm symptom of IBD should make you think that.
So what is the success of invasive and non-invasive neurostimulation therapies? Do you perform these methods as a therapeutic option in your center?
No, unfortunately, I do not have myself experience with this the neurostimulator, and this is because this is expensive, it's not widely available. So I don't have myself an experience on how they work well. The main indication should be the spinal cord abnormalities. In these cases, in my center, the neurosurgeon are using it for this condition, but I don't use myself.
How frequent can we do the disinfection?
Oh, actually, okay, it's no matter of how frequent. I think you should, the thing is you should disimpact them, and you should try to get them disimpacted and get the bowel of your child empty. So actually you shouldn't go through multiple disimpaction. Obviously, in a case treat to disimpact, it will happen, you need to disimpact again, because maybe the maintenance treatment has not worked, the adherence was poor, but you should think how many times you can do that, because actually you shouldn't end up to do it many times, because after your first disimpaction, if the child was impacted, you should reassess very quickly the child to optimize the treatment as much as you can. But if needed, you can repeat the disimpaction.
Okay, so I think I will have to choose one last question because our time is up, but I will combine two questions if that's all right. So one of them is, how long would you take the treatment with polyethylene glycol? And the other one is, are there any steps for reducing the polyethylene glycol when the treatment is going well?
Yes, the first one was how long you can do the polyethylene glycol, yeah?
Yes, how long can
As
you...
I showed in the presentation, this treatment is safe. The length of the treatment in the guidelines, but again, this is for functional constipation, not difficult to treat, is stated that you should give the maintenance treatment for 2 months, and at least after 1 month of treatment, when the child has not had any symptom of constipation, you can consider stopping it, okay? But I don't think this apply for the severe constipation. If this treatment works for more severe constipation, you need to do it a little bit longer, and then what you can do is after maybe some months, consider starting reducing the medication, but the secret is very, very slowly. What do I do is reducing by really, I don't know, maybe 0.2 gram per kg per day, and I give the reduced dose for more days, even 1 week, and I ask the parents to see if there is any change in stool, any change in frequency, anything change, and so they can reduce further. If a symptom start at a certain dose during the reduction, what I do, I say, okay, start again the previous more later the dose was efficacious. So the probably your child will not need more, for example, the dose you were taking before, but maybe half of the dose, and he needs to continue with that dose. This is what I do.
Thank you so much. Unfortunately, we do need to end this webinar today. But I think we are going to have the recording on YouTube. So if you would like to watch it again, you can just go to YouTube and see it again. So thank you so much, Giovanna. It was a really, really great talk. And I hope that it answered many of your questions. So we are going to see each other again next month for gastroesophageal reflux disease. So thank you everyone for your participation, and Giovanna, you were great. Thank you everyone.
Thank you everyone.
Everybody. Bye.
Bye.